Developmental anomalies of the craniovertebral junction and its surgical management are presented here. We will be discussing the Atlantoaxial rotary dislocation. The principles that we have adhered to are the recognition of ligamentous laxity to achieve reduction after traction and to make sure that there is no repeated subluxation because of ligamentous injury. Intraoperative reduction is obtained with imaging, navigation using O-arm CT and subsequently a dorsal occipitocervical fusion with anatomical realignment in this situation. We present an 11-year-old girl who did a backflip and sustained severe neck pain and inability to move her neck. Magnetic resonance imaging at presentation at a local facility demonstrated mild posterior positioning of the odontoid process with high signal intensity behind the anterior arch of the atlas as seen with the arrow. A composite of T2 and T1 MRI at the level of subluxation shows the ligamentous injury surrounding the odontoid process and possible cruciate ligament disruption. CT scan at presentation confirms the Atlantoaxial rotary subluxation with an interlock. She underwent halo crown placement for 3 months, and at the end of that time the halo had been removed for 2 weeks. The patient then presented with persistent symptoms, after which she was referred to our institution. A CT scan at follow-up showed persistent luxation of C1 on C2, with the anterior arch of C1 being forward on the left and the odontoid process displaced. 3D CT viewed from the left as well as from the frontal location better identifies the rotary dislocation and the extent of dislocation, best seen on the 3D CT when visualized from below. The red arrow points to the Atlantoaxial displacement. This patient underwent an awake fiber optic oral endotracheal intubation followed by crown halo placement. Neuromuscular blockade assisted in the reduction. This is monitored with SSEPs and MEPs as well as O-arm CT for documentation. This set of slides documents the position of the patient in the O-arm CT with traction in place. Intraoperative O-arm imaging prior to reduction is seen in the axial and coronal views, followed by post-reduction scan to document the reduction. The O-arm imaging is seen as both pre-op as well as after reduction. This set of images shows the pre-reduction and post-reduction imaging using the traction, neuromuscular blockade, and O-arm documentation. Under the same anesthetic, the posterior fossa, upper cervical spine is now exposed with the patient in a prone position and traction. An occipitocervical fusion is made with an occipital plate, and bilateral pars C2 screws and ligatures are then seen underneath the posterior arch of the atlas. This is to anchor the oncoming rib graft. The occipital plate is intentionally inverted to accommodate the placement of the rods and its connection from the plate to the C2 pars screws. Rib grafts are harvested and split to provide full thickness autograft secured to the occiput, the posterior arch of the atlas, and the axis. Circlage sutures are passed underneath the posterior arch of the atlas and the rods to maintain position of the grafts postoperatively. An intraoperative fluoroscopic image visualizes the construct as well as the position of the endotracheal tube, which should be more than 110 degrees. This patient made a full recovery.